Hi, I'm Bill Sappenfield. I'm professor and director of the Child Center at the University of South Florida College of Public Health, and glad to be giving this introductory lecture to you before my live talk on needs assessment. This talk is about being effective in public health and relates to public health planning. I want to acknowledge that I based a lot of this work initially on work done by Mary Peoples-Shep, Anita Farrell, and Mary Rogers, and we used some of this material in the City Match Urban Data Use Institute, and we've revised it some since then. I would challenge you to think of a time when public health has been effective when it's not had a strong planning process. And so when I talk about the planning process, I talk about it being effective in public health. This is where we put all of our sciences together to create a plan and action that we implement, carry out, where the change that's needed can happen. And this is an essential component for an epidemiologist if you want to be effective within your public health agency, that you need this planning process, and we'll talk more about it. There are a lot of different ways this is broken down depending on who's training this. They may use slightly different vocabulary, they may have slightly more steps, but essentially it breaks down to 6 basic steps. First, you're going to do a needs assessment. You're going to work out in your population, collect your data and information. You're going to come up with priorities in your community or in your state that need to be addressed. From there, you're going to assess the capacity of your agency or your partnership or your collective, and then you're going to start reviewing the strategies of what might work as it relates to those priorities that you selected. And from there, you'll develop a plan. And from that work plan, you'll implement it over time. You'll monitor to see if it's implemented and to see what impact it's having. And then at some point, you'll evaluate it to see how it worked, how it didn't work, how could it be improved, what needs to happen and take place. And that leads you back to your assessment. Is it still a priority? Your next review of strategies and capacity and your next plan. It is a cyclical and ongoing process. And through these cyclical processes, you can really change the program to make a difference in what you're trying to accomplish. And I would tell you from my perspective, again, this is essential for an epidemiology to know and understand so that you can better connect and have your data and research and evaluation go into practice. And when you do this sort of needs assessment, it actually fits into the next step in the planning process. This really helps you develop your logic model. You come up with your priorities, you come up with your strategies and your capacities, and you monitor it. And so these work in sync. These are not differing processes. There are components used throughout. In fact, the logic model is basically part of your work plan of what you're trying to do, talk about to create change that you want it to have happen. So again, these are the steps of what you need to do to be effective in planning and what's capping out. But what happens many times is people's planning process looks more like this. The assessment and the needs and prioritization and the data pieces get signed out to the data unit. You look to the program people to work on the capacities and strategies and developing a plan. Your finance people say, oh, don't come to us at all to figure out what you want to do, and then we'll tell you if there's money available or how we would do it or how we would carry it out. But they're not engaged in that process. Then you implement it, you start to monitor it. But my experience is many people don't do evaluation unless you have a grant that literally requires that you evaluate your project at the end. So that it's really a very fragmented process, so that the planning process related to the block grant and the MCH programs really is not well organized and really limits the impact that we can frequently have within our programs. The other thing I would say is it's presented in a very linear fashion, as if you do one step and then the next step and then the next step. In my experience and practice within a state public health agency or a community level is it never works that way. You never do things in a sequential order. Frequently what happens is you get new money. And when you get that new money, they expect you to implement that into a plan and do it right away. They'd like to see results in 6 months. And you need to have those results to continue to get your funding, and then you can just get into this cycle. Or you're in the block grant and you've been doing the certain programs the same way for a long time, and there's not necessarily a planning process, and so you're already in the middle of everything, and you're trying to impart this process on top of it. The key is that's important. If we want to be effective, we need to have a planning process. So if you get money and you start to develop things on a quick, I specifically say on the fly, you may not be able to do all these steps at first, but you should be thinking about how to integrate them. So for example, you get new money, you still may want to go out and do an assessment while you're putting together and implementing the plan for the funding that you have, so that you can better do that going forward. You want to build in a clear work plan. You want to clearly make it so that it can be monitored, and you want to evaluate it. So eventually those dollars that you got can be in more of a cyclical process. If your program has not really been following this process, this is the first time where you can start having a plan and working on those pieces in a more organized fashion, that there's better accountability and a better refinement over time. Let me give you an example. It's an old example. This is back when I started being an MCH epidemiologist back in South Carolina. However, we still have problems with prenatal care, and it still relates well, and it's an easy one for someone to understand. When I was there, we identified that late prenatal care entry in South Carolina was a major issue, and we still have women who enter into prenatal care late currently. But not only did they have a problem in South Carolina, and we're not doing as well, they also figured out there was a wide black-white disparity. And in fact, that blacks in South Carolina had more late entry into prenatal care than other southeastern states. And that just didn't seem reasonable or appropriate within our state. And so this became a priority that we wanted to address. We wanted to address the late entry problem, and we definitely wanted to address the black-white disparity. I want you to know this was back in the 90s, and we continue to try and find ways to address this disparity. When we did our assessment, we basically find there were 6 major drivers of the women coming in late and the disparities that we had. First, we were underreporting prenatal visits. By that, what we mean is that physicians were not getting their prenatal visits into the hospital so the hospitals could count those to be reported. We also found that physicians were not starting women until the 2nd trimester. They wanted to make sure there was no early fetal loss before they started to spend time in prenatal care and a long plan for the pregnancy and what was coming up. And so they delayed the entry. We also had our own WIC program. Although they couldn't have a waiting list, you basically had to wait a long time to get your first appointment. And at that time in South Carolina, a lot of the prenatal care entry was done in the health department, and it came in coordination with the WIC program. So they were integrated together. Next, when we talked to our hospitals, our community providers, and everybody, although we saw this as a priority of women coming into late prenatal care, nobody in the community, the healthcare providers, the community partners, saw this or recognizes the problem. Well, you're not going to have a community work on, or providers work on providing solutions and coming and making this better if they really don't even recognize it as a problem. We had the traditional issues of transportation and childcare barriers, and a new one that we learned is that unintended pregnancy was one of the leading risk factors for late entry into prenatal care. That if mom didn't want to be pregnant, she didn't get in early and she started late. And so how do we change that paradigm? How do we make it so that women get the help that they need early so they can get into prenatal care and get the care that they need? So we took this needs assessment, and then we looked and drilled down further into each one. I'm not going to go into all 6 components, but I'm going to go into the one on prenatal visits and counting. Since you're epidemiologists, that's one that should relate. When we did our further needs assessment, once we prioritized that this is one of the issues we're going to look on, and we went to part 2 and we dug down deeper into the problem, we found out a variety of issues. First, we had a vital registration manual, but we had gone online and started online entry, but nobody had updated the registration manual so that it related clearly to online data entry. There was no formal process for training clerks when we continued to have turnover and staff at the hospital to collect the data, but no real program that would help orient them to the data that they were supposed to collect, including prenatal care. The hospitals were not transferring the records, and if they did, many of the hospitals didn't really consider that prenatal care, so they didn't include that in the medical record, so their visits didn't get counted. Well, given that the health department was a major provider of prenatal care, that led to a serious undercount. Many of the doctors turned over their records, but they turned them over about 32 weeks. So all those later visits in prenatal care that took place didn't get there, and so they weren't counted. And the reason why all that's important is we know that women are not accurate at reporting their prenatal care visits. So if you really want to know what's happening in prenatal care, you can't just ask the mom. You need to actually see the records. One of the issues that the hospitals also pointed out is that there wasn't a standardized prenatal record. So that if a mother went to more than one provider, it really made it hard to start to count and figure out exactly what happened in each. It made the clerk's job more difficult, and a standardized record would help. Physicians and hospitals needed education on how to collect prenatal care data correctly, because they weren't. We had one person who decided that 7 was the magic number of prenatal visits, and everybody had 7 visits. And so they didn't have prenatal care. So you needed to make sure the people that had that education. We had no monthly reporting system. So when we would talk about how the prenatal care reporting was poor and not what it needed to be, there was no way to track whether what was being done improved it except on an annual basis. And we got that 6 months after the year. So 18 months after you've done something, you might figure out whether it did or didn't work. And that wasn't a good way to go. There were no hospital standards. No clear guidance to the hospitals of what quality they needed to reach up to and how they needed to do it. And those standards can be important. And then you can also have incentives to meet those standards. And there were no incentives. So we as a group worked together and figured out where we thought we had capacity, where we thought we should focus first. And we picked these 5 areas because we thought these were ones that we could work on quickly. And so we did our part for the 6 as the other 5 working groups came up with their plan, and we put those together. And then once we had that work plan, we implemented it, we monitored it, and seeing where we were going. When we did that, we actually saw improvement over time. It went down for whites, it went down for blacks. However, we noticed that everyone was improving, that everyone's prenatal care was getting better, so that everybody was apparently working on this issue. So if we wanted to close the disparity and improve our rates, we needed to continue to work on this. And in fact, when we went back historically, we had found that we've been working on prenatal care back in those early 80s, and that it had been a cyclical process, but we had not built our planning process and a cyclical basis so that we would go from one to the next to learn to better address this. And so that we needed to tighten our planning process down. Again, that's a very simple example of trying to do a planning process and being effective. It is an integrated process. We've been working on prenatal care for years. Only recently had we done more of a formal and stronger planning process with accountability and monitoring and evaluation. And that can be very helpful at trying to shift your resources and your efforts in the right direction. It is not always easy. It needs to be valued and it needs to be important. So if it's really there, why doesn't it happen? Well, the first thing is there's a real lack of political will. By that, what I mean is, although you have to do this planning process, it seems as a function that needs to be formed, and the leadership does not feel like this is necessary to prioritize what needs to be worked on and embraced. It is another task that needs to be done. That's your process will fail if it's just another task that needs to be done. You have competing priorities. In other words, you're in a chaotic time and you don't have a time to focus. However, I would argue if you are so busy you cannot focus, maybe you need to focus so that you can address your busyness and do a better job of it. Many public health agencies actually have limited expertise in planning, and believe it or not, it's not an innate skill that's born. It's something that you're trained in, and it's something that everybody needs to learn their components and understand. So that training on how to do it and how to do it well and how to be people engaged and how to make it change over time and how to make it be effective is a valued skill in terms of making this work. All of us have been part of groups where they're planning and the plans failed, and you spend a lot of time creating the plans and nothing happened. And that's a good way to make sure the next plan fails, because people start out with the perspective that it's not going to work. Most plans fail because there's a lack of accountability. You came up with a plan, it looked good, you put it on paper, everyone's excited about it, you get started, you get a rah-rah, but then no one's accountable to really make sure all those steps take place, because things change over time, priorities insert. It's not as sexy now because it's a little bit older. If you want to be effective, you need to have accountability to make sure that people continue to focus on what is priority and what needs to be done, and that there's accountability to make the changes that need to happen. Again, over time, there is that lack of commitment. You got to keep people there. The people who are in charge need to feel that commitment and hold people to a commitment, because if the leadership loses commitment, then everyone will lose commitment. And last, there may be insufficient resources. Frequently, we plan to try and do things, and there were not the resources there to begin with. And this is where you need to be very careful in prioritizing and being very careful and looking at your capacity and what you can do and you can't do. So who does what? So is it wrong to assign the assessment over to the data people? Don't the program people know more about what their capacity are and their strategies and their plans? The key gets to be, if you want to be effective in public health, somebody as a group needs to be accountable for the whole process. There may be different leads for different steps, but everyone comes back to the same group and accountability and holds everyone there. Again, if the leadership doesn't have a commitment and doesn't have accountability for what happens in a plan, including the data side, it doesn't happen. So it's going to be very important that you have an overview of your planning process and not just any one step. So when Title V requires a new needs assessment, it's only part of your larger effort. So why is planning important to an MCH epidemiologist? Well, first, I am an MCH epidemiologist, and I think it's so important I'm trying to teach you and bring you up to speed. It is something that you need to understand if you want to be effective in a practice world. First, you provide the necessary data expertise, and you need to get in with the program to understand what the program's dealing with so that you can give them the best data they need to direct what they're trying to do. It is not them about coming to you for a data request and you just give them the data asked for. It is an interactive, integrated process of making sure that people get the data they need to create the change. You are part of that team, and this is your role of that team. And if you're not part of that MCH team, then you're an external person, then data will not have a driving role. And data-driven is an essential part of a planning process. It will also provide you common priorities. My Title V directors would always ask, what are the data priorities or the evaluation and epidemiology unit's priorities? And I would say, our priorities are your priorities. Tell us what you all are working on, and our priorities need to align with that. It may be a little bit broader than that, but generally there should be a very close connection between those priorities, and you have a common priorities. You have a common language and a common framework so that what you're working on connects to what they're doing, and you're using the terminology and pieces and outcome that they are so that it makes for a synergistic process. Again, you need to lead to a data-driven decision-making process. So an epidemiologist is your only way that you're going to be able to do that. If there is no planning, then it's highly likely that your data will not lead to as much impact as you would like. And as an epidemiologist, there's nothing worse to me than to be spending a year on a project and have nothing happen after I spent all that time working on it. And lastly, you're going to need to help assist them in translating your findings to action. One, they may not understand them. Two, they may not know how to relate them. And three, they may not see that what they're doing relates or doesn't relate to what you're trying to present. So as part of that MCH team, you need to be not only trying to provide them the data they need, but you need to help work with them on that translation of data into action. I would say that your involvement in a planning process of whatever your agency and your group is doing is almost essential if you want to be effective as an epidemiologist and see changes in the lives of women, children, and families. I'll be happy to answer any questions when we get to the lecture portion. Feel free to email me if you'd like to learn and get answers sooner, and I look forward to actually talking to you more directly through virtual format. And we'll talk soon.